Unfortunately, there were 2 grade 5 events, or about 0.5%. How do you talk to patients about that risk? With all this, robust efficacy and success in the clinic in terms of the therapeutic advantage we have now with ADC therapy, the first line, compared to the Cleopatra-like regimens, this comes at a price, doesn't it, in terms of toxicity?
Yeah.
What are some of the common toxicities that you worry about with T-DXd?
I'm really glad you're asking that, because this is where, I think it gets complicated, and I think we know that we aren't going to have data to support all of the decisions we're going to have to make once this becomes everyday use. And mostly in the first week after exposure to T-DXd, we find patients can have some fatigue, can have nausea. And that's something that when you think about that in a short term, okay. If you're thinking about that for years, that's tough. So that's one big difference, I think, between what we're used to giving and what would be now, given that the T-DXd was given continuously. And another, again, is the alopecia. You're looking somebody who has a devastating diagnosis, and there was a real gift in being able to say, hey, you may have hair loss now, you may not if you use cold cap, but you won't have it for the years that come when you're on maintenance.
Right.
And so clearly, only a minority, fortunately, have that. But when I think about quality of life, that is important for our patients. And then, of course, there's the discussion of pneumonitis. Now, having said that, I'm not sure what the real-world pneumonitis data will be if people start to consider altering the regimen for what the trial did, meaning perhaps shortening exposure to T-DXd, because we know that the median onset of pneumonitis is months, right? So if you end up using just an induction, not to say that was what the
mostly in the first 12 months.
Yeah.
Right.
So the question is really, what will that pneumonitis rate be if people find it appropriate to terminate the T-DXd at one point and move to maintenance? These are questions that we have to answer.
Yeah. Now, the incidence of pneumonitis overall is about 12%.
Yeah.
Decibel was 9. Unfortunately, there were 2 grade 5 events, or about 0.5%. How do you talk to patients about that risk?
So this goes back to the very early question you asked me, which is, how is this for everyone?
Right.
I think that this is a very different conversation than you and I are used to having with patients. We try to reassure them. Yes, you have an incurable diagnosis. Yes, this is devastating, but here's all the hope that we can lay out for you in this first consult, right? And in that hope, we'll say risks of therapy, but we don't have to touch upon death from therapy as a really palpable potential outcome. Now we are obligated to discuss this unlikely but potential risk. I think it's important to understand that some of this is also in the hands of the clinician. I find it very important when you talk to the patient about this, they have to understand that. But also, when I have spoken to patients about this T-DXd and about the risk of pneumonitis, which can be life-threatening, they get it, and they understand that quite often, if we do teamwork monitoring, we can catch things early. And so I find it really crucial that the patient and the family are well aware of what the symptoms of pneumonitis are, which is not just shortness of breath or cough. Unexplained fever is a common one, right?
Absolutely.
And that your nursing staff, your triage team, your APPs, everybody who touches the patient's space understands when to think, and think early and scan early.